The beauty of the membership model is, I tell patients, like a gym membership, is you can use me as much or as little as you want.
What does the first day look like?
We have an hour.
Right.
You can relax,
right.
and you can breathe, and I can breathe.
You just simply do not get in the normal medical system.
Exactly.
All right, so welcome back to The Mover. My name is Catherine Reber, and I'm a doctor of physical therapy working out of Kinetic in Westchester, Pennsylvania. And today I'm joined by Dr. Matthew Kavalek, who is a board-certified family medicine physician who recently co-founded his own direct primary care clinic called Blue Ocean Health, located in King of Prussia, Pennsylvania, which is super impressive. But thank you so much for joining us today.
Yeah, absolutely. I'm glad to be here.
Absolutely. And happy St. Patrick's Day.
Yes, happy St. Patrick's Day. Yes.
Are you Irish?
No. I don't know. My parents say I'm a mutt. I probably have a little bit of Irish in me.
Okay. Yeah. What are your parents, do you know?
Hungarian, I think a little bit of Czech, I think a little bit of Irish, a little bit of German. Like I said, we're a bunch of mets in our family.
I love it. It's awesome. Yeah. So tell us a little bit about your life growing up, like pre-med school and everything.
Sports was probably the main theme growing up. Played a bunch of sports, soccer, basketball, baseball, golf. Ended up kind of sticking with basketball and golf. Mm-hmm. Wasn't good enough to play college sports, but I did like sports. So just want to kind of be in that realm. I didn't really know what I wanted to do. Thought maybe like physical therapy. So I went to undergrad for exercise science.
Okay. That's what I saw too. And I was like, I wonder if he was thinking the PT route.
I just wanted to be in sports. Yeah. And I figured that was the best way to kind of stay into it. And then in undergrad, we had a human anatomy class, human anatomy and physiology. And did really well in those. I really liked those. And for some reason, I was just like, I want to take this to its fullest extent. And it kind of pushed me into, medicine route, wanting to go to medical school.
Sure.
Type of thing.
Okay.
So, yeah.
You said you did not play sports in college. Did you do any like rec leagues or anything like that?
No, I'm an exercise junkie. I wasn't playing intramural sports or in a league or anything like that. I was working out all the time, to be honest with you.
Nice. I went to the University of Connecticut and I played a bunch of sports in high school as well. I'm from this area. And when I went to college, I was like, okay, I'll at least join the club team, right? Because it was a D1 sport. I wasn't obviously good enough to play D1. But I went to the tryouts and they had everybody run it was almost like 10 miles.
Oh, really?
And it was obviously a weed out thing.
Yeah.
But I think I made it 3 miles in. I was like, I just simply can't do this. This is so crazy. What
sport was that?
It was for soccer, but it was the club team. Yeah. I'm like, this is ridiculous. So I ended up just doing, rec leagues and everything. Yeah. So are you from this area? Are you?
Yeah, I'm from Bucks County. Okay. Grew up in Warrington.
Okay. And where'd you end up going to medical school?
New York Medical College in Westchester, New York. Yeah.
Gotcha. Did you like it?
Medical school?
Yeah. Or even like that area?
I didn't get to experience a whole lot of it. Medical school, I try not to remember too much. They really did a very good job of beating the crap out of us.
I couldn't even imagine.
Yeah. So couple times going into the city. But for the most part, it was what you would think it was. Locked away in your room, studying all the time. Like there were times where you were studying literally like 16, 17 hours a day. Like that's all you did. I
could see it like in a movie. You just locked in on the books.
I always say I didn't have any emotion during that time period. I wasn't depressed. I wasn't happy. I was just like getting through it.
Absolutely.
Yeah. So.
And was there a time during medical school that you thought like family medicine is the way I'm going?
Yeah. I mean, so I came in like the classic jock, wanted to be an ortho bro. So I went in thinking that, ended up hating the operating room. I don't like surgery. I knew that right away. So I was like, well, that's out. I really liked emergency medicine just because it's a blend of things. It's a very acute situation. It's life or death. There is small procedures. I like the different personalities that are attracted to emergency medicine. It's a lot of athletic people. So it was either that or I actually was going to do emergency medicine. The reason I switched was, and this will kind of transition into like why we started the clinic, but so the first day of med school, I'll never forget, we had a lecture, and what they teach you is the most important, way to arrive at the right diagnosis, the right treatment plan for a patient is to really take an in-depth history and do a really in-depth physical exam. So they taught us that, and the first and second year of medical school is really hammering that home. Like that's what you really need to do to be a good doctor. Third year comes along is where medical students transition. They go from just classroom work to they're in the hospitals and the clinic settings, really getting more hands-on. And I just remember the transition where the attending physicians were like, yeah, I know what your professors are teaching you in school, but this is how medicine actually works. And it was very much like, you need to go as fast as possible. You have a ton of patients to see. The volume is insane. Get as much as you can, but that in-depth kind of workups, it's there's not as much emphasis on it. So I didn't like that just because of the way my mind works. I don't like missing things. I don't like just skipping over details. It just doesn't work well for me. And I'm very much like a free market guy by nature. So I remember going home, like I was in the hospital. I was like, this does not look fun at all, to be completely honest with you. Everyone looks burnt out, frustrated, patients, the doctors. So I just went home and I Googled free market healthcare. Direct primary care popped up. There was actually a conference in Florida 2 weeks away. So I remember my roommate, who's now my business partner, came home and I was like, hey, like, this seems pretty cool. Let's go check it out. So we swung it with our attendings at the time. They're like, yeah, you can go. So we went down and it was like it was just a completely different vibe, meaning all the doctors were very happy. They really wanted to practice medicine. A lot of them were like, hey, this saved my career. I didn't want to practice medicine anymore. I wanted to retire and do something else. But, this saved it. And everyone says you have a moment in medical school where you're like, that's what I want to do. And that was my moment for me. I was like, oh, this is what I want to do. And that was 2017. And so from then on, I was like, I'm not going to do emergency medicine. I'm switching to family medicine so I can do this. And that's kind of how we transitioned into, ultimately going to residency for family medicine and doing what we're doing now.
Wow, that's awesome.
Yeah.
So tell me a little bit, how did that conversation go when you were kind of deciding, who am I going to do this with? Because, of course, your business partner is somebody that you knew from medical school.
Yeah.
So was it kind of like when you guys went to that conference, did that just happen organically?
Yeah, I mean, we're both we're like the same person almost. There's a lot of views that we have that are very similar. He came from a sports background. He actually played soccer, semi-pro. Okay. He always wanted to do his own thing. He kind of told me that from the beginning. So it kind of naturally was a very easy transition for us. And there wasn't any long conversation or sit down. I remember we were getting done residency and couple months away from graduating and we just were having a cigar and I was like, are we doing this? And he was like, yeah, let's do it.
You had a lot of movie moments and you're like,
well, there wasn't a whole lot of thought. There's plenty, looking back on it was kind of stupid and naive. There's a great quote that a DPC doc in Kansas says, and he has it on his wall. He's like, we do this not because it's easy, but because we thought it was going to be easy.
Sure. Of course. I'm sure it was way more
It was slap in the face. I was like, wow, naive, understatement, but
it'll certainly pay off.
Yeah.
Now, since, that time in 2017 when this was, kind of sprouting in your head and from where you are today, do you feel like just in general across the country, do you feel like these types of clinics are popping up and are more prevalent?
Oh, yeah. So I always say in 2017, when I went to the conference, not very many people knew about it within medicine, meaning if I would talk to doctors, they'd be like, I've never heard of this type of thing, let alone just the general public. And when I went to residency, it was the same thing. It was, I've never heard of this. What is this? Right. Now people know what it is. Not only doctors definitely know what it is. They have different opinions on whether they agree with it or not. But there's a growing understanding of it. There's every year more and more doctors are just getting fed up with the, what I call just the system in general. Sure. And they're either quitting, retiring, or they're doing DPC. So you're seeing this kind of just you see the upward trend of this movement. Sure. And then on the flip side, you look at the general public, and it's the same thing where they're like, I'm getting really sick and tired of. It's really hard to schedule an appointment with our primary care doctor. I have to wait 6 months, and then I wait 6 months to go to my appointment, and I get less than 10 minutes with them, and it's like, I'm done already. Like, what are we, did you even ask me any questions? Like, what am I doing type of stuff. So they're getting more and more sick of it. So they're looking for alternatives. They're finding DPC. So the pitch for me is easier and easier. I almost, if someone calls me up as a consult, I just listen and tell them a little bit about the clinic, and they're like, great, what are the next steps to sign up? Like, it's not that hard of a sale anymore.
Absolutely. And I think when we're talking about the insurance-based model, like for patients or the clinicians, I mean, I think it's a lot of hoops and ladders you have to jump through for everybody. Yeah. And it just makes the process so elongated. And when you're in pain or you're having like a systemic issue going on, just that time is not helpful for anybody, you need to be seen quicker, right?
Yeah. Well, definitely get into the office or be seen quicker. But when you have that time, in that office,
right? Yeah.
Spending it actually like figuring out what the heck is going on, how are you going to actually treat you, and,
absolutely,
following up and making sure it's all working and stuff like that.
Take me through when you guys first began the business. What was like the hardest thing about starting your own clinic, and maybe something that was easier than expected?
The hardest, no paycheck.
True.
Residency gets done, and even if you weren't making very much at all residency, but still you're getting paid every 2 weeks, and it's like, nope, you're not getting paid. And plus, you're spending money, for office space and insurance stuff. So that was a huge transition. Mm-hmm. I would also say mindset wise. So in residency, you didn't want people to come in. You're so busy. You're like, oh, they didn't come in. Great, I get a chance to breathe. Type of things. Whereas the clinic, the mindset shifted to, how do we improve our pitch, our offering, the value we can provide to patients to get them into the door, as patients. Sure. So I would say those were probably the hardest things about it. Easiest thing, I would just say it was nice to finally be able to, sit down. I'll never forget. So one of my patients he came with me, he was my patient in residency, and I'm joining my practice now. And, he comes in and assuming it's kind of similar to residency where you don't have a lot of time, you got to rush through everything, right? Really going fast. And I'm just like, we have an hour. Right. You can relax and you can breathe, and I can breathe. You want some coffee? You want some water? How's your day going? Type of stuff. So it was like, this is it. This
Which
is
you
nice.
Just simply do not get in the normal medical system.
Exactly.
Which again is stressful for not only the patients, but it's probably stressful for the doctors too. Yeah. And I think that's what's so unique about your situation is I do know quite a few physicians in the area that have been in like big medical systems and then left it to join a DPC practice or started their own. Yeah. But I love how you just kind of knew from the get-go, like, that is not what I want. I want something that's going to kind of suit my lifestyle and my personality and the way I want to treat and be the best doctor I can.
Yeah, I think definitely personality-wise, it was a much easier transition. I knew I couldn't. I get frustrated, with the system. I think it manifests a lot easier than I think other doctors can suppress it a lot better than I can. Yeah. I knew that. So I was like, I'm not even going to attempt it. Sure. Type of thing.
So for people that do have insurance, they can still come see you, right? Like, do you run into any issues there?
No. So it's a great question. So DPC, it's a membership-based practice model. Okay. So our patients, they pay a flat monthly fee. It's kind of like a gym membership. So that portion is not covered by insurance. Okay. But other things, so they need lab work done, they need imaging done, a chest x-ray, a CAT scan, an MRI, they need to see a specialist. Like, those all things can be covered by insurance. Okay. If they have good insurance, or if they have Medicare or something like that. But the beauty of the membership model is, I tell patients, you can use me as much or as little as you want. So like a gym membership, if we, get done our appointment today and you're like, we addressed a lot, but there's a couple more questions I had, you can literally schedule tomorrow with me. Or you can schedule next week with me, or we're starting a new treatment with you. It's touch and go in terms of how it may benefit you. There may be side effects, but the beauty is, you can literally text me tomorrow, the next day, the next week. This is how I'm feeling on this new medication or this treatment or whatever. And should we make any adjustments, et cetera, et cetera. So, that's kind of how the model works. Yeah.
Who are your typical clients? Like, is it somebody that's coming in saying, I have elbow pain, I have chills, kind of like a whole system of things? Or is it somebody that's just coming in like, I have ankle pain, can you fix it? Who do you see?
So I say it's family medicine is cradle to grave, head to toe, anything and everything.
Amazing.
So, we have infants in our practice. We had a 105-year-old in our practice. We have 10-year-olds, teenagers, 25-year-olds, 45-year-olds, 75-year-olds, men, women, and they come in for different reasons. You have kids who their parents bring in because they feel like they're being unheard in the pediatrician office.
Sure.
You have adults who have a lot of complex issues going on and they have a lot of specialists, but there's no quarterback or anyone that's like, hey, like I'm overseeing everything, making sure everything makes sense.
Sure.
I have men who come in who are really getting beat down with life and they have low testosterone. So we're helping them with that. I have women with hormone issues that we're helping them with menopause, hormone therapy. Mm-hmm. Yeah. So literally, all of that.
Okay.
So there's no like ideal patient or this is my patient.
Okay. What does the first day look like? What is the first, what are you evaluating or, are you ordering blood work? I'm sure it's different for every case, but just walk me through like that first day.
Yeah. So every first appointment is an hour. We sit down. The first question I always ask is, what are your health goals? Like, what do you want to accomplish by joining this clinic? So we go through that. Then I go through their health history. So, what have they been diagnosed with in the past? What medications do they take? Surgeries, family history, all of that. We go into lifestyle things. Obviously, do you smoke? Do you drink? Do you do any drugs? But what's your diet like? Are you exercising? What's your sleep like? Are you stressed just with work or life? We go through all of that. And then at the end, if they haven't had blood work done in, a year or more, then we discuss potentially getting blood work done. If they have had blood work done, I review it. I always tell patients, bring in whatever you feel, health-wise documentation you have that, I may benefit from reviewing. So a lot of times patients will bring in like a stack and I'm not going to get into it today, but like I'm going to review it and I'll get back to you type of thing. So yes, that's the first appointment. And then that kind of sets us up moving forward. And it varies in terms of, how frequently I need to see them moving forward because everyone's different in terms of their health. But yes, that's the first appointment.
And then do you do like telehealth visits and all that stuff?
Yeah. At the end of the first visit, patients get my cell phone number. So I tell them if they have a question, a concern, they want to schedule an appointment, it's as simple as texting or calling me. Many appointments can be phone visits or telemedicine visits, so they don't have to, I say you don't have to drag your butt here in the office unless I need to see you in the office type of thing. So yeah, there's a lot of convenience factors with that as well. You have people who are like, they're at home and they're not feeling well because it's flu season and obviously they don't want to go to urgent care or something like that, and they don't even want to get out of bed, so they can just text me, hey, Dr. Matt, here are my symptoms. Should I be concerned? Is it okay? What should I do? Do I have to come in the office? Should I, should you call in something? And we can kind of like triage from that perspective and stuff like that.
Yeah. I love how you look at everything because I think there's a perception that pretty much like DOs are of the people who are kind of seeing like the whole picture, trying to treat it in more of like a holistic way. But I feel like what you guys have been able to do is kind of create that environment. And I think even from a PT perspective, it's sometimes something that we fail into of not looking at somebody as a whole in general, because we always have the musculoskeletal lens on. And, we may be able to help somebody get better, but then we can't reach that last 15% of their recovery. And frankly, it could be due to their sleep habits, their diet, other comorbidities that may be having that won't, from a healing perspective, can't get them to that 100%.
Yeah, definitely. But I think that's where the time, why the time is so valuable and so important. So I always try to approach my care for patients the way I would want to be treated, meaning like I want a doctor who knows me, like really knows me, like everything about me. And if I have blood pressure, cholesterol, or sugar issues or whatever, like I don't want the first thing to be like, here's a pill. Are they necessary at times? Absolutely. Am I anti, medication? Absolutely not. What I tell patients is if we can really hammer home and get under control the lifestyle stuff, your sleep, your stress, your exercise routine, your diet. If we can get that foundation under control, you're doing everything possible from that angle.
Sure.
A lot of these things will self-correct without the need for medication.
Right.
Or you can get off your medications. And then if we do all that, you're like, doc, I'm doing all of that. Like, I am on point, and it's not, okay, you need medicine. Some people need a little bit of help.
Right. Of course. Yeah, absolutely.
So that's kind of how we approach it. But that takes time. If you have 15 minutes with someone once every 6 months, you're never going to be able to do that.
Absolutely. And that's a thing that we talk about in our clinics a lot is, people go see their doctor and they're like, I was in there for 10 minutes. I didn't even get a chance to pull out my phone to ask my questions on my notes. Everyone does it. I even do it when I go to the doctor because I'm like, all right, I only have so much time. I got to ask my questions fast, and I need to get the answers or else I'm going to forget. And then I have to email them through the portal, and no one's going to get back to me. We talk about it in a PT world. I love my job and I'm very thankful for it because I do get to know my patients so well because I'm seeing them so much, and it's a very different relationship. But again, I love this DPC model because they get to have that similar type of relationship with you, just based on spending the time with you, which is awesome.
Yeah, I always say the list exists.
Exactly.
There's so many people that come in, I got my list, they got 10 questions. And from a doctor, I get it. From a doctor's perspective, though, a lot of these things, there's a lot of nuance. There's a lot of, explaining or even further questions. You may ask a question, okay, well, now I have a bunch of questions based on the question that you just gave me type of thing before we can determine what's the best next step for you type of stuff. So that's where I think patients get frustrated, but doctors are just banging their head against the wall like, I can't do this.
How many medical professionals or physicians work in your office?
For our clinic, it's 2 of us. It's just me and my business partner. We work in a co-sharing space, so there's a bunch of other doctors in there. For Blue Ocean specifically, it's just me and him.
Gotcha.
Yeah.
Now, do you guys see certain types of conditions? If somebody comes in and they're like, I need, I'm a male and I need some help with my hormones, are they primarily seeing you or do they see your business partner as well?
We both do both. So there isn't, one doc who does one thing, another doc who does another thing. We both, we have the same breadth of knowledge or what we're able to take care of and not take care of type of things.
Okay. Let's talk a little bit more about some of the hormonal therapies and stuff. I'm a pelvic floor therapist, so I see a men and women for pelvic floor issues and deep core, low back. And this is a topic that comes up all the time, and especially with the HRT conversation. I would love to know your thoughts on all that stuff or how you go about it.
Yeah, so we'll go men and women. For men, I always tell them we look at labs and symptoms. So I'm looking at the patient and they tell me I'm really getting moody or having issues with anxiety, depression. I can't put on any muscle mass. I have a really poor exercise recovery, issues in the bedroom with really low sex drive or erectile dysfunction issues. We go through all that. We look at their lab work. So what are their testosterone levels look like? But we also look at estrogen levels, prolactin, a bunch of different things. We take that. So we put those things together. And then we say, again, so what could possibly be causing this besides just giving you TRT? Mm-hmm. Is it you have undiagnosed obstructive sleep apnea? Is it you have a varicocele in your testicle that's impacting the ability to produce testosterone? Is it an issue with your brain? So we try to go through that and make sure we're not missing anything from that perspective.
Sure.
If we do all that, we talk again about the lifestyle stuff. Okay, well, how do we improve everything from a lifestyle perspective? And then the final thing would be are you a good candidate for TRT? Mm-hmm. Is it safe to do? Mm-hmm. These are things we have to monitor, stuff like that. So from a male perspective, that's how we kind of approach it. Okay. From a female perspective, there's been a paradigm shift recently in menopausal hormone therapy within mainstream medicine, meaning even 5 years ago, it was very much don't touch it type of stuff. But a lot of doctors are re-examining the data and saying, no, we kind of messed up. We should be treating these women. But it's a similar conversation. What are your symptoms? Are there any contraindications to starting hormone therapy? Are you a good candidate? Will this potentially help? Labs are a little bit different, especially for women who are in the menopausal transition. They don't really help that much because they fluctuate so much. So we're really looking at symptoms from that perspective.
Right.
But those are the conversations we're having with women. Yeah.
I have a question. So for the male perspective, of course the females are going through their perimenopausal state, their menopausal state within that age range. Is that similar? Is it a similar age range for men? It's not like they're going through menopause, but when do things start to go through a roller coaster for their hormones?
I would say you start seeing it mid 40s through their 60s.
Okay.
So kind of similar overlap.
Male menopause.
In terms of that. Yeah, I do have men coming in who, they want to get on the shot and stuff like that, TRT, whenever performance. There's a lot we can be doing outside of that before we need to go to the medication aspects. You're working 100 hours a week and you're not sleeping. Let's start there.
Yeah, absolutely right.
Type of thing. So
I recently gave a little talk to our company with a couple of my coworkers about menopause, and we were going through all the symptoms and just systemically how it really, there's so many things that can be affected by it. And one of our male coworkers was like, I think I have menopause. It's I have all this stuff. We're we'll chat later with you.
Yeah. You should see a doctor.
You should see Dr. Kavalek. That's so funny. Yeah. So, okay. And I think it's been so interesting. I mean, I've even had some female clients that have started HRT, and it is such a crazy difference, just even from little joint aches and, things that frankly they were was part of their PT, that all of a sudden they start HRT and they're like, oh, I'm cured, I'm healed. And they're like, I don't think it was anything you were doing. I'm like, I don't think it was anything I was doing either. But I think it was, it's just so interesting. And it's one of those things you just don't want people to, or especially females, to feel crazy when they are experiencing all these different types of symptoms, because I think not many people know how vast the symptoms can be in terms of what you may be experiencing from the fluctuation.
Yeah, I think an issue with medicine today is everything gets siloed. So everyone's trying to be a specialist. You don't have time. So it's I'm just going to focus on this one little area, and that's my thing, and that's it. But if, so someone comes in with joint pain, go see the sports medicine doctor, go see the physical therapist. You're having anxiety and it's okay, go see the psychiatrist. Right. You're having issues with your sexual health, go see the sexual neurologist, the gynecologist type of stuff. Instead of saying, is there a linchpin to all of this?
Exactly.
Type of thing. Yeah. Instead, they're on 6 different medicines, seeing 6 different doctors. It's not really helping. Yeah. Stuff like that. Not to say there aren't patients that's the treatment, but there's a lot of patients where that linchpin is missing. Right.
And I think that's a tough thing too, because once people get placed on quite a few different meds, and of course I know the doctors are kind of overseeing it, seeing if they are clashing with each other, but I think there are so many side effects that can pop up from just that, and then they're kind of dealing with new things that are popping up, and it becomes so frustrated. I would be frustrated too if all of a sudden you're getting random symptoms that you've never had before. Yeah. It's literally just because of the meds you're on,
Polypharmacy is a thing.
Absolutely. Let's talk a little bit about weight loss, because that's another huge topic these days, of course, with the GLP-1s and everything. Where does your clinic stand on that? And do you guys promote it? Are there ways that you teach people how to do it? Because I think that's the big misconception is, I think a lot of people think, let me just go on this and hopefully I just become perfect. And how does that work?
Very similar approach to anything else that we talk about in our practice. So someone comes to me and says, I'm thinking about, should I start a weight loss medicine? Mm-hmm. We go through everything. What have you done in the past? The foundational lifestyle, factors. What are you eating? Have you seen a registered dietitian? What's your exercise routine like? What's your sleep like? All those things factor in. I really try to hammer home with my patients. We need to get this foundation really strong type of thing. But if you have someone who's doc, I've done all the diets. I've seen the registered dietitians. I've seen the nutritionists. I've gone to personal trainers. Nothing works. I've tried really, really hard. Then we have a conversation. Okay, here are the potential options from weight loss medicine standpoint. Here are the potential side effects. Here's what you need to monitor. you do need to continue to strength train. You do need to make sure you're eating a decent amount of protein, because you are going to lose more protein. Muscle mass is very important as you age. Bone mass is and strength is very important as you age. So we want to make sure that we retain as much of that as we possibly can. It's inevitable when someone goes on the weight loss medicine. If it works really well, they're going to lose muscle mass. It's just going to happen. You could diet. If you lose 70 or 100 pounds, you're going to lose muscle mass. So it's not something unique from that standpoint. But just having that conversation with them. And on the flip side, I have patients who are like, well, I don't want to be on this long term. Is there any potential way I could get off of it in the future? The data so far says that the far majority of people are going to regain the weight. But we do have that conversation of, if you have those habits in place, you're much less likely to regain the weight. Not saying you won't, but if you have very strong habits from a lifestyle perspective in place, then you could keep the weight off. And we have that conversation with too. Hey, you've lost this weight, you've done a great job. We can start experimenting, meaning let's reduce the dose and see how you tolerate it. Right. Does the food noise come back? Do you start eating more? Do you feel like you're getting more weight? No? Great, let's reduce it again. And then keep going. Oh, you're putting on more weight? Well, okay, well, let's stop there or go back up, type of thing. But it all depends too on their values, what they care about. Right. So I have that conversation. I'm not incentivized to put patients on medications. I'm incentivized to just get them the best healthcare possible and listen to them. So that's kind of what people keep coming back to me for. So it's kind of how we approach it.
Absolutely. That's awesome. And I think it boils down to just habits too. I think, the people who may need some of these medications I'm not saying all, but some people, are a little bit sedentary, maybe not eating the best, maybe not sleeping the best, like you said. And I think starting with that foundation is so huge to kind of, again, almost like rewire some of their habits, that they're kind of, that's the key to all of it, right? And then the medication is kind of there as a helper. Is that what you would say too?
Yeah, that, and also some people it's a kickstarter, meaning because of their weight, they're so deconditioned physically that it's really, really hard for them to get back in exercising. They're in a lot of pain, which makes it really hard for them to go start exercising. Sure. So if they're able to lose some of that weight, the pain goes away. The ability to walk or get on a treadmill or do some basic exercise is not as daunting of a task, so they're much more willing to do it, and it kind of creates that nice upward cycle for them type of thing, which I've seen. It's very hard for people who are used to exercising to be it's not that bad. Right. You know how to auto-regulate, and you're in pretty good condition yourself. But when you think about when you first do something really hard, there's a lot of times I've done workouts I'm never doing that again. That sucks so bad. I'm never doing that again.
You shake on the way out.
Yeah. So you can imagine someone who's really that deconditioned, they're probably thinking the same thing. That to us, it's this is an easy workout, but to them, that's hard.
Yeah. Even from a PT perspective, you can always tell the people who have maybe exercised in the past and those who have not, because those who have not, may take muscle soreness, which it is sore, they may take it as I'm in pain. And those are two very different things, and it's sometimes good to educate people on pain science and, or just this is your muscles breaking down. And it's actually good to have that soreness, not too much, but some level of soreness, that your muscles are rebuilding, you got to have the appetite and the protein intake to start to rebuild some of that muscle. Yeah. So of course that brings me to my next point. So you said you're an avid exerciser.
Yes.
What's your go-to? What do you like to do?
Well, it used to vary. I was big into powerlifting in medical school. I got older and just got out of that. Right now it's just whole body strength training with a little bit of conditioning at the end. So I like to do a lot of burpees or sprints or things like that, just to kind of stay right. Well, they're not fun, but
they're horrible.
They're good finisher. But yeah, that's kind of what I like to do.
Absolutely. Yeah. What's the heaviest you've lifted back in your prime days?
Yeah, deadlift was 655, and squat was. I didn't get to 500. I never got to that. It was 495. I always wanted to get to 500. But
didn't Jalen Hurts, didn't he squat 500?
Yeah, but they're athletic freaks.
That's great. You're 5 pounds away. Well, that's pretty good.
It was a combo of things. You're young. You're kind of dumb. Meaning you have to, your mentality when you have 500 pounds on your back or you're about to lift that much weight is doesn't matter what's going to happen. You're going to lift the weight. Versus now I'm like, I could injure myself. That could not be fun type of stuff. But yeah.
How do you approach trying to get somebody who's never exercised to exercise?
I make it as simple, ungodly simple as possible.
Me too.
1 push-up.
Love that.
That's it. Like, I just, 1 push-up once a week. You have to do that for 4 weeks and then report back to me.
I love that.
Yeah, because it's the only way it's going to work.
Yeah.
I have a buddy from as a kid, like, he's the exact opposite, meaning like he hates working out.
Yeah.
And there are times in our lives where he's like gotten the exercise bug, wants to get in shape, and he makes the classic mistake where he'll go and he'll do like a 3-hour workout 3 days a week, and then he'll quit like 2 weeks in.
Too much. Yeah.
Way too much, way too quickly.
Yeah.
So I always tell people, you need to make it, you have no excuse. Like, there's literally nothing you can say that excuses you from doing 1 push-up once a week. You have nothing. It's not a time issue. It's going to be like hard.
Right.
It's not because you have lack of equipment. You get on the ground, do 1 push-up, and then you're building that habit.
Sure.
Okay, you did 1 push-up once a week. Great, let's go to 2.
Yeah.
To 2? Yeah, 2.
Yeah, exactly.
I'm thinking about you 5-10 years from now, not today.
Even myself, of course, I'm a physical therapist, so practice what you preach. I used to work out 5-6 days a week, whether it was running, strength training, what have you be. And then I had a baby. He's 11 months, but I had a baby. And, probably 4 months in, I was like, all right, I got to get back to my same schedule.
Yeah.
I'm like, I can't do this. There's no time for that. And I totally feel for the moms that, when I was still, in the pelvic floor world treating, and I was, asking them, okay, like, you could do 4 times a week. Now I'm kicking myself. I'm like, I can't do that, and you just realize how much time out of your day a baby, takes, and it's great.
Yeah.
But, it's as long as, even for me, just going for a walk is huge, and it's good for me. It's good for the baby to get outside, and that I need to accept, and I am accepting that is exercise. Just move your body, get your heart rate up a little bit. Yeah. It doesn't need to be super crazy,
No, definitely.
So I totally
agree with that. Yeah.
Well, this was awesome. Yeah. Thank you so much for coming in. And where could our viewers find you? If you have like a website.
The website, it's blueoceanhealthdpc.com. That's probably, the best way to reach us.
Excellent. Yeah. Okay. Awesome. Well, thank you so much. This
thank you for
great.
having me.
And again, happy St. Patrick's Day.
Yes, happy St. Patrick's
Day. I'm going to go drink a Guinness.